Hello, this is Dr. Beck. I'm a urologist at Logansport Memorial Hospital, and today we're having a brief video discussing a new technique we've adopted at Logansport, which is called Aquablation. But going backwards to that it's the management of men with benign prostatic hypertrophy, or BPH. Essentially, it's men with seen the commercials with getting up at night, weak stream, what we call lower urinary tract symptoms. And with most non-cancer processes, it's quality of life. And we initially treat with medication. Tamsulosin or Flomax is the primary one. Well, in my office, I see patients who have failed those. Usually the primary physician, they've tried Flomax and they've failed medical therapy, meaning they have persistent symptoms as affecting their quality of life despite being on the medication. Or in more severe cases, they present to the emergency room and they're unable to urinate and they require a Foley catheter. And more severe is they actually develop kidney damage because their prostate's blocking the urine. When that happens and they fail medical therapy, the next step is surgery. A typical presentation of BPH, which is benign, it's not cancer, benign prostatic hypertrophy. It isn't necessarily a large prostate. You can have, think of an orange, and in the middle is your urethra. You can have a big prostate growing out, so it's enlarged, but it's not obstructing the flow of urine. Or you can have a tiny prostate, and really it's the capsule, the rind of the orange, that squeezes down and obstructs the flow of urine. So you can have two symptoms with BPH: obstructive, by putting the finger over the hose, weak stream, inability to empty the bladder, post-void dribbling. You finish urinating, you zip up, the more urine leaks out, and you're unable to empty your bladder. Those are obstructive symptoms. You can have irritative symptoms, which is frequency, urgency, nocturia, getting up at night. That's the symptoms, right? That's how a patient presents with symptoms. There's also signs of BPH, and that is sometimes more difficult to appreciate, because if the patient doesn't see you for the symptoms, we never see the signs until it's kind of more progressive. And what can happen? Signs can be trabeculation of the bladder, and I see that when I scope patients where the muscle of the bladder becomes hypertrophied and it's thickened. And over time, it gets so stretched out, it's like a floppy bag, it doesn't contract anymore, leading to urinary retention, requiring catheterization. Further, not delay in treatment, but later presentations of BPH include upper tract deterioration, where your kidneys, urine drains into the urine of the bladder. Bladder's a reservoir, and it fills to a certain volume. The brain gets a message, I'm full, I want to urinate. It contracts, it generates a pressure, and comes out. When that pressure gets so great, because it's going past the resistance of the prostate, the pressure gets transmitted up to the kidneys. And you can get obstructive nephropathy. So the obstruction, like a kidney stone, but the obstruction is from the prostate. And the bladder's contracting, and it can't get past the prostate. So that pressure, just like a kidney stone, gets admitted into the prostate, and patients can develop renal insufficiency. And 20, 30 years ago, maybe 40 years ago, patients presented with renal failure, and it was secondary to BPH because nobody recognized it. And they would come in with bilateral hydronephrosis, meaning swelling of both kidneys. Why both kidneys? Because it's outlet obstruction. It's the prostate blocking the bladder, which blocks both kidneys. And the goal of treatment is to hopefully to avoid those signs of progressive BPH, which is bladder trabeculation, overdistension of the bladder, and ultimately upper tract deterioration, meaning loss of renal function. So treatment is, initially it was, okay, well, we'll prevent you getting up once at night and have you, not go as often during the day. But it's also preventing progressive deterioration of bladder function and renal function. So we're treating the symptoms, but that is what brings patients into the office, and that's what drives therapy. But we also got to keep an eye on bladder function and kidney function, which patients may urinate well and feel like they're doing well, but could have a high voiding pressure, meaning if your bladder is good enough in the beginning, it can overcome the resistance of the prostate, so you don't have as many symptoms, but you're still developing that high pressure. So we're kind of recognizing a little bit more now than we did maybe 15, 20 years ago about bladder health, and that perhaps we need to intervene earlier. That intervention may be a medication, but to recognize that there is long-term sequela secondary to untreated BPH. So that's one of the reasons why we're referred to urologists. Again, usually if it's a sign where patients presents with bilateral hyperplasia or renal insufficiency, we don't want to see him there. We want to see him 6 months earlier, a year earlier, when they're getting up twice a night to prevent this. The traditional surgery is called a TURP, which is transurethral. So we're going through the urethra, resection of the prostate. 50 years, 60 years. Gold standard, 95% success rate, 2 or 3 days in the hospital, but the efficacy or the success rate is very high. Side effects. One is you're in the hospital for 2 or 3 days with a Foley catheter. One long-term side effect is called retrograde ejaculation. So when a male ejaculates, semen comes out of the penis. After a TURP, there's loss of anterograde emission, or you get retrograde ejaculation, meaning semen doesn't come out. As well as the hospital stay, bleeding, and the catheter. So in an effort to decrease side effects, but maintain the same efficacy, the same success, over 20, 30, 40 years, different procedures have been developed in an attempt, again, to decrease side effects, but you got to maintain that same success rate. Because like chemotherapy drug, if you have less side effects, but it doesn't work, it's not a good trade-off. So after adopting many, as every urologist throughout the country and the world, Aquablation, which we've had been here since December of 2022, has maintained that balance as a new procedure of similar efficacy or the closest efficacy to a TURP with less side effects. So success is in the 90 to 95% range. TURP is 95%. Typical, I would say 90% of men, 95% of men spend the night in the hospital and their catheter is removed the next day. This is unlike a TURP where it's in for 2 or 3 days. The aquablation is like a water jet that goes, if the prostate's in orange, you're putting a scope transurethral through the urethra, through the tip of the penis, into the prostate, and it's a maybe 2 or 3 millimeter, extremely high pressure focused jet that opens up the prostate, creates a channel. And we use an ultrasound, and it is a robotic type of system where I map out the prostate on ultrasound, and I essentially find the anterior, the top, the posterior, the bottom, the apical or front of the prostate, and the posterior part of the prostate, and map out the prostate using this computer. And then the jet is programmed by this computer to stay within those boundaries. And that allows the efficacy because it's opening up the prostate, but it decreases potential side effects, or maybe less than 1% with an aquablation. And the reason the toxicity or the side effects is lower is because we are able to radiographically with ultrasound map out the anatomy per individual with the ultrasound, plug it into the computer, and then that high pressure water is programmed by the machine that we put in by the anatomy or per the anatomy per patient. Unlike the TURP, it was visually, you just resect. The efficacy was great, 95%, because we were resecting the prostatic tissue. The problem is there was the retrograde ejaculation, the bleeding, the longer hospital stay, and potential urinary incontinence. So by utilizing the ultrasound and the computer-guided water system, we're better able to avoid the apex where the sphincter is, where antegrade emission is controlled, as well as the base of the bladder. There's less bleeding. So it really has improved outcomes and quality of life for patients who fail medical therapy. Now, a patient comes in, TURP, Aquablation, UroLift, UroCup, all these procedures were here. You start simple, Flomax, 0.4 milligrams once a day. If it works, we're done. If it doesn't work, Flomax twice a day. And the whole point of the medical therapy is to preserve quality of life from a urinary standpoint and avoid the morbidity, which is greater than taking a pill, of any procedure by just taking Flomax. Now, if the conservative therapy, medical therapy fails, then the patient, in my opinion, is left with a choice. Live with it or redo something. Well, what is that something? Well, that something was TURP. And it works really, really well. And sometimes we have to do it. The problem is there are some side effects, a little bit longer of a hospital stay, a little bit greater blood loss, but it works. But now Aquablation, we're getting greedy where we want the same efficacy, but with less side effects. For some patients, there's even more minimally invasive procedures that we can do in the office or under even less sedation with even less side effects. So if somebody has significant comorbidities, even though the efficacy of these other procedures is a lot lower, it's much safer, and that sometimes we have to make that trade-off if somebody has significant cardiac or pulmonary problems. But we've had a lot of success with the Aquablation, and success is defined when you're having a new therapy in not just outcomes, meaning we do a procedure, there's no side effects, but it doesn't work, not the point. So we do have good success. It's not 100%, but it's good. There's a healing process, and it seems to me that the perception of doctors and nurses and hospitals and patients that anything done with a robot, it's 100%, I'm perfect 5 minutes after the procedure. There's a healing process like everything else. You get a knee replaced, it's immobilized for 3 months or 2 months. Or prostate, you can't do that. And you're urinating the next day, and it's going through a raw surface, so it burns. There's frequency and urgency. And that doesn't matter what procedure, it just takes time to heal. But we've seen, not just not at Logansport, it's other centers, and 1 or 2 perhaps in the state, in Chicago and other areas in the Midwest that are doing these, that the success, the efficacy, the benefit to the patient is in the 85, 90, 95, in that range, and we do see a lot less side effects. So the goal is with any new procedure, as I said, is to maintain that efficacy with as few side effects as possible. But again, the best way to avoid side effects is to avoid surgery. That's why we always try some type of medical therapy first.